vitrectomy, achieve an extensive vitreous clearance, be able to see the retina on table, but graft haze would still be an issue. There would be graft rejection down the line, and also it's a very laborious process. You require the cornea colleague to come in, and it becomes a very extensive affair. Or you could go ahead and do a temporary keratoprosthesis and a vitrectomy. Little better clarity because of the artificial glass nature of the keratoprosthesis, but still a laborious nature, large team, and the fact that at the end of the surgery you need to replace the keratoprosthesis again with a cornea becomes a big affair. Herein is where endoscopy has a good role. It allows you a good vitreous clearance. The retina can be assessed on table. Corneal surgeon is not required, and it allows for the natural corneal clearance. You may have the corneal issue which is temporary. So if you can bypass that and deal with your posterior segment, naturally the cornea may clear down the line. But there will always be a learning curve because this is something which is not traditionally taught in training programs. We use the Endoptics system at our institute, no financial interest there. It is a composite probe with a light pipe, a camera and a laser inbuilt, available both as 20 gauge and 23 gauge, and also in straight as well as the curved configuration, the curved one being used for glaucoma management for endoscopic cyclophotocoagulation. We'll run through quick 3 case scenarios where we apply this for posterior segment management. So the first is a 9-year-old female, history of trauma with a wire 6 days prior to presentation, history of corneal intervention elsewhere 3 days ago, and presenting vision of PLPR accurate. So we can see a repaired corneal tear, some tissue adhesive in place. We can see an immune stromal ring there. Posterior segment showing lot of echos. So primarily this patient underwent a vitreous stap which grew Enterobacter species. So if you put the entire scenario together, you have a post-trauma etiology, a gram-negative organism, a young patient, and no posterior segment view. So something where you really need to clear out the vitreous cavity, but you are not able to do it conventionally. So this is where if you enter using an endoscope, you are able to see the exudates much more clearly as it is visible on the screen. And effectively, I am able to clear the entire cavity and reach right up to the retina. So you'll see here that the macula disc are largely visible, and you can clear out the entire cavity well. So remember what the cornea was looking like, and this is what we end down the line with post-operative steroids, antibiotics. So we have allowed this cornea to clear out naturally. The posterior segment has settled down, and visual acuity of 6/18 N12 for what we began with is really good for this girl. Second scenario, a 52-year-old male, reduced vision in the left eye along with progressive whiteness. Presenting vision was PLPR inaccurate, was on topical antifungal and antibiotic drops, and was advised evisceration elsewhere when the patient came to us for a second opinion. So the eye had a cornea which was melting, lot of infiltrate in the cornea, and in our emergency room, a tissue adhesive and bandage contact lens was done to maintain a tectonic globe integrity. Posterior segment, as you see, had lot of echos. So going by the look, going by the fact that already an opinion for evisceration was there, patient is in extreme pain and is okay with the fact that, the eye would be removed if it gives him comfort. We still thought, let us give it a chance and see what the posterior segment looks like on table. So this case actually was a sort of a learning for me that many a times B-scan overestimates the problem in the posterior segment, and not everything that looks on B-scan is infective. So look at the posterior segment here. Look at what the B-scan was, look at what the posterior segment is. There is hardly any involvement of the posterior segment. So if this eye gets eviscerated, this is something which possibly is not correct. So the posterior segment was so good that the cornea person was called up on table, and an immediate keratoplasty was done. Post-op week 1, post-op month 1, post-op 3 months, vision of 2200. So someone who possibly could have got eviscerated at one end is now having an eye which is really functional. Time permitting, the last case, this was a part of a cluster endophthalmitis that was referred to us. Again, you can see the cornea has an extreme haze. Here what you can possibly do is just a vitreous tap, or you will have to do one of those extreme procedures that I mentioned. Going ahead, we entered this eye endoscopically, which allowed us to clear out all the exudates effectively and reach the entire retinal surface. I will skip the rest of the video because it's similar to video 1. Just letting you know that this eye was then filled with silicone oil because a couple of breaks were noted on table. And then you come back to perform your silicone oil removal and as an elective process have the cornea surgeon come in and replace this cornea with a keratoplasty. So herein you are doing a keratoplasty in an eye which is no longer quote unquote hot. It is an eye which has settled down and that helps your graft to take up better and the chances that this will reject down the line become lesser. So the clarity was sort of good enough for me to give a visualization on table, and here you can see that the retina was largely doing fine in the post keratoplasty scenario. So we have collated our experience of endoscopy in endophthalmitis and realized that the evisceration rates whenever the keratitis is present with endophthalmitis as compared to a literature of 25 to 30% incidence in our subset had come down to 3%. We've also put across work where we've shown that if you do a prompt endoscopy in an eye which otherwise has corneal edema, that allows the cornea to settle down and you actually do not require a corneal intervention down the line at all. And even if you do require, and do this keratoplasty in a deferred manner, you are likely to have the cornea that survives much longer than what it would have if it would have been done primarily. This is one article where we have collated the entire review of the intraocular endoscopy knowledge. So in conclusion, anterior segment trauma and endophthalmitis both can have an hazy anterior segment. Conventionally, posterior segment access can be achieved by a K-Pro or a keratoplasty to allow a vitrectomy. But an endoscopic approach will circumvent this necessity and avoid unnecessary keratoplasties and also allow for a natural resolution of the opacity in appropriate cases. So thank you so much for your kind attention, and I don't know if you have questions. Time for questions. Yeah.
Thank you.
Thank you.
You can come here and sit next to me as we connect. We can ask you a few questions and save the time. So we'll go with Dr. Kakan and then Dr. Habib. We're just trying to get around. Come and sit next to me here, if you don't mind, so we can use the time. So a quick question here. So the problem with the endoscopy is the resolution. You use 23 gauge. Have you tried the 19 gauge? Can we have a short answer so we can have more questions?
Yeah, so I largely use 20 gauge now because the 23 gauge, though convenient to enter with sutureless entries, the camera size is so small that you have a very compromised visualization. So the 19 or the 20 gauge works much better.
Thank you. Let's ask our panelist here, any experience with endoscopy?
Well, I know this from Frank Koch from Frankfurt. He did a lot of studies with this, and I know his experience, and I can only congratulate you on your results. So I think I haven't done it myself, but I think it's a feasible approach, and we should continue with this.
For me, I don't do the endoscopy. For cases like this, I use the Eckart corneal prosthesis, and sometimes if I don't have the graft, I use the same cornea and I postpone the.
No, I don't have any experience, but excellent videos, and I think there's a very fair point of using endoscopes when patients have corneal issues. Excellent videos again. Thank you.
So next speaker is Dr. Kakan speaking about anti-vitrectomy. Thank you so much, Hussein.
Thank you so much, Ahmed, and thank you, Meom, for inviting for this talk. Before going for the talk, can I put the same question? So, how many are doing the anterior vitrectomy through the limbal approach? Can they raise the hand? So it's 5, 6 people. And how many of us is doing vitrectomy through pars plana? 1, 2, 3, 4. So 5. Mostly the VR surgeons. So we are talking about the problem that facing the anterior segment surgeons also. So it's not easy to have all these things. So I will go through for the both part of the world, the anterior segment surgeons and for the retinal surgeons. So anterior vitrectomy from the pars plana approach. Usually the vitreous loss is after the posterior capsule rupture. In many instances with the torn posterior capsule, it is possible to avoid the rupturing the hyaloid face. That's the most important thing, that you should avoid to rupturing the hyaloid face. So what happens whenever we do have the posterior capsule rupture, the surgeons, whether it's anterior segment surgeon or posterior segment surgeon, he is in a hurry to withdraw the phaco probe. And that's the biggest mistake that the surgeon makes at that time. Actually, he shouldn't have withdrawn, he should keep the pressure inside the eye and fill the eye with the dispersive or viscoelastic. Because removal of the tip abruptly unplugs the incision and allows the anterior chamber to collapse. The sudden posterior pressure gradient rupture the intact highlight. That's the problem where the problem starts. So one must often rely upon indirect clues. How you can understand that I am having the posterior capsule rupture is the sudden deepening of the anterior chamber. This sign can be recognized easily, but the second sign is much more easier, that you are unable to rotate that cataractous lens that you were rotating very easily in the start of the surgery. And that's the biggest sign, you having difficulty in rotating that cataractous lens. That's the most important sign that you can have at that time. So I will just share a video. So this is normal routine cataract surgery going on. Posterior subcapsular cataract surgeon is happy doing the basic surgery. He has done the rexes, everything. He is doing the rexes, and here he will do the routine phaco emulsification. It is NS1, NS2 cataract, and phaco is done. He is calm and quiet. Few cortical material there. So here he recognized something and he wants to visualize the posterior capsule, but the things has been started not good. So he's removing the cortical because the surgeon has recognized that something is not good behind these few chunks of the lenses. So here he saw it and what he did wrong. Without putting any viscoelastic, he just withdraw the probe, and you will see clearly what I was mentioning is happening here. You can see whole the anterior highlight is abrupting like a volcano into the anterior chamber. Now he is putting some viscoelastic there and trying to maintain the integrity of anterior highlight, but that complications has enlarged the posterior capsule. This undesirable cascade of events can be avoided by the filling of the anterior chamber, the viscoelastic, prior to removing the phaco tip. That's the main key. A viscoelastic is injected through the side port. Opening, the surgeon moves the foot pedal position onto the zero. So if we get the nucleus drop, early recognition of posterior capsule rupture is often the key to avoiding the drop nucleus. The similar